This is the International Academy for Clinical Hematology around the globe and across the hematology field. It is 6 p.m. in Paris, 1 p.m. in Jacksonville, and it is my great pleasure to welcome you all to this new webinar brought to you by the ICH. Today, it's my pleasure to welcome you to this ICH webinar dedicated to the management of mantle cell lymphoma. As advancement in research and treatment continue to evolve, optimizing patient outcomes requires a nuanced understanding of emerging therapies, risk stratification, but also personalized treatment approach. Today, we are honored to have a leading expert in the field, namely Dr. Madiha Iqbal, who is an assistant professor at Mayo Clinic and who is a top expert in the field of B lymphoid malignancies, especially when it comes to transplant, immunotherapy, and novel treatments. Today, she will share the latest insights on therapeutic strategies, novel agents, but also real-world clinical applications. This session aims to provide a comprehensive overview of the current landscape, discuss challenges in clinical practice, but also explore future directions in mantle cell management. So we look forward to an engaging discussion. I do encourage you to actively participate with your questions and insights. We'll have a live Q&A at the end. So thank you for joining us. And Madiha, let's begin. Welcome and thank you for joining us.
Thank you, Dr. Moti, for having me and for the very kind introduction. Hello, everyone. So today we'll be talking about the management of mantle cell lymphoma and really focusing on update. And this is, as we will just talk about, is become a very exciting area. And it is really one of those B-cell non-Hodgkin lymphoma histologies that has had some very exciting advancements. So we're going to be talking about most of those today. So as I start, I have no relevant financial disclosures in reference to this presentation. So just a little bit of an historical background as we will build upon this is that up until really a couple of years ago, this is how we approach a patient with newly diagnosed mantle cell lymphoma. And some of this still stands true. So going back to what I was saying that, up until a couple of years ago, this is how we used to approach patients with newly diagnosed mantle cell lymphoma. And some of these, approaches still stand true, but we will build on this historical understanding of mantle cell lymphoma today. So when we first have a patient with mantle cell lymphoma come to our clinic, we first evaluate whether these patients need treatment, i.e., are they one of those non-nodal, low burden leukemic type of mantle cell lymphoma who could be observed, versus they are those patients who have bulky disease and are in need of urgent treatment. So moving on to patients who do need treatment, then what is your next step? And that's mostly been to evaluate whether these patients are eligible for intensive treatment, essentially high DAC, high dose cytarabine, as it is one of the cornerstones of treatment in mantle cell lymphoma, or they are ones that are ineligible. And once that is determined, one of the most commonly used regimens that we've had for ineligible, high DAC ineligible, or let's say our older patients, has been Rituxan bendamustine. And based on several studies, notably the STILL and the BRIGHT study, and this is followed by rituximab maintenance. And then when we come over to the young and the fit patients, we have had strong data supporting the use of R-CHOP alternating with R-DHAP or the Nordic regimens, followed by a consolidative transplant and rituximab maintenance. So with this being our background of how we have been managing mantle cell lymphoma patients for years, we can see that we've had notable improvements over the decades from 1990, as shown here in the curve, to early 2000s, but the disease remained incurable and challenging. And intensive treatments such as the Nordic, transplant, and maintenance, all very three powerful regimens, can yield a PFS of 7 to 10 years in young patients. However, they're really a small subset of patients who are truly eligible. And 5-year overall survival, despite all of these treatments, has been estimated to be about 65%. And most, if not all, patients will experience disease relapse. We have targeted agents in the second line, but as we will discuss later on, the efficacy of those agents is relatively limited. So the field and the, really evolved to focus on improving on our frontline treatments to see how we can really, move the needle in mantle cell lymphoma. And this has done through several, I would say, several strategies that have all kind of combined to what we're going to be talking about today. And these I've divided into several areas because different approaches have been taken from all these angles to that same goal. And that's the optimization of chemoimmunotherapy, the addition of targeted agents to chemoimmunotherapy, reevaluating the role of transplant, development of chemotherapy-free approaches, optimizing maintenance, and then also using MRD-guided therapies or MRD-guided approach. So now we'll talk about each of these approaches briefly. When we look about optimization of chemoimmunotherapy, here too we have approaches that were designed for transplant-eligible patient populations and those that are transplant-ineligible. When we look at the transplant-eligible population, there's this study, which was a phase 2 study where patients who were otherwise young and fit received 3 cycles of bendamustine Rituxan, and this was followed by 3 cycles of cytarabine and Rituxan. You can see that high overall response rates and CR rates of 92% and 88% were observed in this study. And at a median follow-up of almost 3 years, PFS and overall survival were very encouraging at 83% and 92%. This regimen was followed by transplant and had the very unique advantage of limiting anthracycline exposure and very excellent outcomes as discussed. And then in the ineligible population, we know that BR is an effective regimen, but then again, cytarabine is a very effective agent too, one that mantle cell lymphoma is exquisitely sensitive to. So this regimen was developed where a low dose of cytarabine was added to BR for our older patients. And this, again, regimen turned out to be very effective with a CR rate of 91% and median overall survival and PFS were not reached at a follow-up of 86 months. So a fairly long follow-up supporting the use of this regimen. Now, we talked a little bit about, some of the optimization of chemotherapy regimens, but now moving on to the second way through which frontline regimens are being, transformed, and that is the addition of the Bruton tyrosine kinase or the BTKIs to the chemoimmunotherapy. So here we're showing the results of the trial. We'll discuss the triangle study, which I'm sure most of the people, in the B-cell lymphoma world are familiar with. So we'll dive a little bit in this study. So this was a beautiful, large effort by the European Mantle Cell Network and had 3-arm parallel group randomized controlled trial, where here you can see the A arm was your control arm, which is what we talked about as our historical, standard of care. And the A plus I arm, where ibrutinib was added to your control arm. And the I arm, which was like the A plus I, but autologous transplant was omitted. In all 3 arms, patients did receive rituximab maintenance for up to 3 years after the results of the Lima study were published and happened during the course of the trial. Now, here are the results of the trial. And when we looked at 870 participants, so a huge trial and a median follow-up of 31 months at the time of the initial publication. And A plus I, which was the experimental arm, was shown to be superior in terms of failure-free survival to the control arm. And what they were also able to show was that the control arm was non-inferior to the I arm, essentially concluding that autologous stem cell transplant may be omitted if a BTK inhibitor can be given in the induction and the maintenance strategy. The comparison of the A plus I, the experiment versus I arm, was not available at the time of the publication, but we'll see those results in just a bit. Notably, grade 3 to 5 infections and hematological adverse events were higher in the A plus I arm. Also, I wanted to show this data where greater benefit was noted with the addition of ibrutinib in the experimental arm A plus I for those patients who had high risk phenotypes, such as those with high Ki67 index and high p53 expression. But it's also important to keep in mind that the trial population was generally of low risk, as only 15% of the patients were high risk according to the MIPI scores. Now, here is the update of this trial that was presented at last year at ASH in December of 2024. And here they presented the comparison of the two ibrutinib-containing arms. So at a median follow-up of now 53 months, the A plus I arm failed to show a failure-free superiority over I. And they also were able to confirm their previous results regarding the superiority of A plus I over A, as well as superiority of A over I not being confirmed. And they also showed that compared to the arm A, which is your control arm, the ibrutinib-containing arms were associated with superior overall survival. So in conclusion, the triangle study concluded that ibrutinib-containing treatment without transplant is superior over transplant-containing treatment without ibrutinib in terms of both failure-free survival and overall survival. And the triangle study concluded boldly that ibrutinib plus R-CHOP combined with Madiha, followed by 2 years of maintenance ibrutinib, should be the new standard of care for younger mantle cell lymphoma patients and essentially ending the era of transplant for mantle cell lymphoma patients. But we have more data, and that is great, but it also complicates how we put everything together. So then we had the results of the ECOG study. So you can think of it as the US version of Triangle, although there were some notable differences. Here too, it was designed for patients who were otherwise transplant eligible, but the upper limit of age cutoff was 70 in this study. And here we had 3 arms, where the first arm, which being the control arm, was patients receiving 3 cycles of BR, followed by 3 cycles of rituximab and cytarabine. The experimental arm, where acalabrutinib was added to the control arm. Acalabrutinib was given continuously in the first half, and in the second half, it was given 2 weeks on and 2 weeks off. And then there was arm C, which included BR plus acalabrutinib. An important difference, especially when we're contrasting with the triangle study, is we have known for several years now that molecular remission is an independent predictor of outcomes post-induction in patients with mantle cell. So in this study, they specifically designed the primary endpoint to be a composite endpoint of PET-CT complete metabolic response in combination with peripheral blood undetectable MRD. And that was defined to the level of 10 raised to the power minus 5. So again, at ASH last year, a lot of exciting mantle cell data that we were discussing. They presented the initial data from this trial, where 359 participants were randomized. It's also an important point to note that the BR plus acalabrutinib arm was controlled by the Data Safety Monitoring Committee based on interim futility analysis in fall of 2022. Median age was 61. You can see that majority of the patients were intermediate risk in this study. Baseline clonal sequence for MRD detection was identified in 95% of the patients or samples. And 260 patients had end of treatment MRD results, and these are the focus of the primary analysis, which we are discussing here. So if you look at the results of this study, the composite endpoint, which we discussed, the PET-CT complete metabolic and undetected MRD rates, they were essentially similar across the 3 arms, as well as there was not much difference across the 12-month PFS and overall survival between the 3 arms. Treatment discontinuation due to AEs was also fairly similar across the 3 arms. So what they concluded was that high PET-CT rates were seen in all 3 arms, and that BR, the control arm, can be considered as a standard induction. And they also noted that the addition of acalabrutinib to the standard arm added toxicity without notable improvement in efficacy, suggesting that there is perhaps not much need of adding acalabrutinib to BR-CR. And interestingly, although the BR plus acalabrutinib arm was closed early, they did find out in analysis that it was indeed the least toxic arm and had similar efficacy and can be an appealing option to avoid high-dose site therapy. So here in the ECOG trial, essentially, in conclusion, we're not seeing the benefit of adding BTK inhibitors to frontline induction. Now, these were the data in regards to, as I discussed previously, transplant-eligible population. Now, what's going on in the transplant-ineligible population when we come to addition of BTKIs? Here, too, we have interesting data with the SHINE trial, which was presented a couple of years ago, where ibrutinib was added to BR and was continued until disease progression or unacceptable side effects, and maintenance Rituxan was continued for about 2 years. At a median follow-up of nearly 7 years, the median PFS was in favor of ibrutinib group, but overall survival was similar within the two groups, and there was slightly higher incidence of death actually in the ibrutinib arm. This study was then followed by acalabrutinib, the ECHO trial, where acalabrutinib was substituted for ibrutinib, and essentially the trial design was otherwise similar. And here we're seeing, again, we saw a similar trend with high response rates in favor of the acalabrutinib arm, as well as median PFS favoring acalabrutinib arm. But we also were able to see a positive trend favoring overall survival with the addition of acalabrutinib. And this was despite 51 patients crossing over to acalabrutinib after experiencing progressive disease on the placebo BR arm. Based on these data, the FDA here in the United States approved the combination of acalabrutinib and BR for previously untreated mantle cell lymphoma, and this essentially being the first approval of a covalent BTK inhibitor for frontline management of mantle cell lymphoma here in the US. So we've talked a little bit, and we'll have a summary discussion of how to put all these results together. But moving on to other ways in which we have made a dent in the frontline management of mantle cell lymphoma is reevaluating the role of transplant. When we look at transplant, most of us are familiar with the European network study several years ago, which randomized patients following CHOP or R-CHOP to either transplant or interferon maintenance. The long-term follow-up demonstrated survival benefit favoring transplant, and this essentially was a study, one of the landmarks supporting the role of transplant. However, there were several questions that still remain because induction, as we know, induction regimens evolved during the years. And an important question that came to rise was that with the evolution of these novel or modern chemoimmunotherapy regimens, where does transplant stand? And then with rituximab maintenance, how does that impact transplant? And then, although we also recently have the triangle study supporting the mission of transplant in regimens that have frontline BTK, another important question, even with the triangle study, remained that whether it is the addition of BTKI that is responsible for the lack of benefit of transplant, or whether there is no benefit at all for transplant at all, even in the control arm. So with those questions in mind, the ECOG Cooperative Network designed the EA4151 study, where patients who received induction and achieved a complete metabolic response underwent MRD analysis. If they were found to be MRD negative, they were then randomized into an arm A, in which patients received transplant followed by rituximab, or arm B, where they received rituximab alone. Patients who were MRD positive at end of induction were recommended to proceed forwards with autologous stem cell transplant and rituximab as per standard of care at that time. ASH 2024 saw the results of this study as well. 650 patients were assigned to the 4 treatment arms, median age of 60 years. 37% of the patients were high risk. Induction regimens were intensive, and intensive was defined as those who had high-dose cytarabine containing regimens, and non-intensive were 27. BTK inhibitor was actually given to only a minority of patients in this trial at 7.2%. So at a median follow-up of 2.7 years, there was actually no difference in overall survival in PFS between arm A and B. And this difference was maintained across the subsets based on risk factors such as the MIPI scores. And this difference was also maintained, meaning that there was no difference between overall survival based on induction regimens also. So essentially, they were able to conclude that in the era of highly effective induction and maintenance regimen, mantle cell lymphoma patients who are in first CR and have undetectable MRD, which was defined as 10 raised to the power -6 by clonoSEQ, do not benefit from consolidative transplant. Also, exploratory analysis for the arm C, to remind everyone, that's the subset of patients who are MRD positive, and then converted to undetectable MRD positive, converted to undetectable MRD status post-transplant, had superior survival and PFS compared to those who remain MRD positive. And this just essentially reestablishes the importance of MRD as a prognostic marker. But it's also important to see that it's really a minority of patients out of the whole subset, and being 17 and 13, essentially close to 30 patients who were MRD positive at end of induction. Again, showing that we are, in this day and age, likely to get away with not offering transplant to the majority of our patients with mantle cell lymphoma. So, so that was a bit about the role of transplant and how that is rapidly undergoing evolution, and it's very interesting to see. Moving on to another strategy, which is one that is very exciting as well, and is one that patients are also very interested in, since it offers the opportunity to omit or have very limited chemotherapy exposure. So these are strategies such as the doublet, and we'll talk about the triplet approach, where there is heavy reliance on novel agents in the management. So here I'm showing some of the results from the Window 1 study, where ibrutinib was given in combination with rituximab, and thereafter patients were assessed. And based on their responses, they were given varying treatment cycles of rituximab and hyper-CVAC. You can see that high overall response rates for intent to treat population was achieved, and PFS and overall survival were also fairly impressive at 79 and 95%. And interestingly, they also really demonstrated the efficacy of upfront novel treatment-based induction, where they showed that the outcomes of patients who did not receive any chemotherapy or received fewer than 4 cycles of chemotherapy were not significantly different. Building on to similar approaches, there is also a doublet approach that you can utilize in patients who are otherwise older or unfit or transplant ineligible, where they can just be treated with BTK inhibitor and rituximab. In this study, acalabrutinib was continued, whereas maintenance rituximab was done for 2 years only. And you can see very impressive, plateau in curves seen with median PFS and overall survival not reached at a median follow-up of over 1.5 years. Other exciting approaches in the realm of limited chemotherapy and chemotherapy-free approaches are these studies, such as the OASIS study. Here we're seeing very effective, most effective novel agents that we have available with ibrutinib, venetoclax, and obinutuzumab, all combined and given together in patients with untreated mantle cell lymphoma. A CR rate of 86% was observed with 6 cycles of induction, and overall survival and PFS being 100% and 93% respectively. But important to note that there was a high rate of grade 3 or higher AEs, suggesting that this is again something that you need to be cognizant upon of, though outcomes are excellent. This is more of a modern approach with your second generation covalent BTKI, but essentially a similar approach where acalabrutinib is combined with venetoclax and rituximab, an overall survival, an overall response of 100% and a CR of 71% noted. Here too, you're seeing high rates of grade 3 AEs, and the most important AE being actually COVID-19 infection in this study. Talking about novel approaches in frontline management, Revlimid, an immunomodulator, which many of us are familiar, when treating our patients with B-cell non-Hodgkin lymphoma, is also an effective agent in mantle cell lymphoma, and we have long-term follow-up data supporting its efficacy in combination with rituximab. So this is another novel approach where Revlimid and rituximab was combined with acalabrutinib, so-called the ALR study. And you can see a beautiful plateau observed with PFS and overall survival at a median follow-up of 19 months. And 7 patients who were an MRD negative CR were able to discontinue the study, discontinue acalabrutinib and Revlimid. Essentially, a treatment or time-limited approach can be utilized with such approaches. And another study where venetoclax was substituted instead of BTKI, and again we are seeing very high response rates and median PFS and overall survival not reached. And this study is giving you essentially the advantage of reserving BTKIs for later lines of therapy. So many excited studies and approaches that we have just discussed, and many more to come. Some of the studies to look out for is the Mangrove study, which is going to be randomizing patients, older patients, to zanubrutinib plus rituximab versus BR. So we will be able to see whether a novel approach is superior or not to our traditional BR approach. And then the AVO study, which is again giving our upfront, most effective agents with acalabrutinib, venetoclax, and obinutuzumab, and has a treatment naive as well as a relapsed refractory cohort. We know immunotherapy has significantly changed the treatment algorithm in B-cell non-Hodgkin lymphoma and as well as mantle cell lymphoma. And as such is the theme in oncology, immunotherapy is also trying to move up front in the management. And we have the Window 3 study where AR, acalabrutinib and rituximab, will be followed by CAR T-cell therapy in the form of brexucabtagene. And we'll talk shortly, bispecific antibodies in the form of glofitamab has also shown some notable efficacy in the relapsed refractory setting, and studies are ongoing to evaluate it in the upfront study in the upfront setting in combination with other novel agents. And then lastly, a little bit about maintenance strategies. One is another approach or a central part of our frontline management. And with the omission of transplant, as we have discussed with the triangle as well as the ECOG study, the maintenance therapies are poised to become an important part of treatment algorithm. However, there are important questions and questions that I believe are still yet to be answered and should be and will be the subject of future studies, such as what is the toxicity of such regimens of maintenance itself. And maintenance are usually low intensity treatments, but over time patients do tend to accumulate toxicity, and whether time limited or indefinite strategies are the ways to go. And how does living in an era of pandemic with the recent COVID-19 and still we're often struggling with flares and new variants, how does that factor in? So there are ongoing studies such as what I've shown here with the ibrutinib maintenance and other studies that are ongoing, but that's an area where still more concrete data is yet to be seen. And then lastly, talking a little bit about risk stratification in mantle cell lymphoma. So risk stratification, as we see in most of our diseases that we encounter, also remains an important area in mantle cell lymphoma. Some of the traditional risk factors that have been validated in mantle cell lymphoma include Ki-67 index greater than 30%, TP53 alteration, blastoid morphology, POD24, as well as the presence of CNS involvement in certain mutations, as I've shown here, CDKN2A, Notch1, Notch2, and SMARC4. And as shown in the figure here, patients who have these high risk factors, their outcomes are significantly inferior to those who do not. It's also important to know that mantle cell lymphoma, compared to other counterpart non-Hodgkin lymphoma, is associated with a high rate of genomic instability. So considering all of that, efforts have been made to focus on these subset given their inferior outcomes. And TP53 mutated mantle cell lymphoma is one of those high risk subset of patients with mantle cell, estimated to be about 10% of all newly diagnosed. And even with our best aggressive chemoimmunotherapy regimens, the median PFS is estimated to be less than 1 year. And very limited responses are seen with novel agents in the second line. So with that in mind, this was a very interesting design study which was conceived where a treatment naive was just specifically designed for treatment naive TP53 mutated mantle cell lymphoma. Zanubrutinib, a second generation BTKI, was combined with obinutuzumab and venetoclax, and a limited treatment duration of 2 years was chosen in this study. And after 24 cycles, zanubrutinib venetoclax could be discontinued if patients achieved an MRD undetectable CR. Median follow-up was about 1.5 years. And you can see very impressive response rates in this difficult to treat subset population with a CR of 88% and 1 year PFS of 84% and 16-month PFS of 75%. Here is some of the grade 3 toxicity, and not very high, and the highest being neutropenia at 12%, but still not completely not still a decent number of or decent amount of grade 3 toxicity. So based on these data, the bovine regimen is actually now a recommended option in the NCCN guidelines for TP53 mutated mantle cell lymphoma. So we talked a lot about frontline management of mantle cell lymphoma, but how do we put all of these results together? So this is my attempt to put and provide some guidance to the listeners in the audience for how to manage your newly diagnosed mantle cell lymphoma patient that needs treatment. So we'll again pivot to understanding whether this is an old or unfit patient who cannot tolerate treatment or is one who is young or fit. If you have an old or unfit patient, based on some of the data from the ECOG study and the patient's otherwise standard risk, BR followed by maintenance rituximab as we stand still represents a decent option to consider, and one that allows you to reserve BTKIs for later lines. But if you have a high-risk patient, we have very nice data from the ECHO trial. Acalabrutinib in combination with BR followed by maintenance rituximab can be chosen. Here too, in terms of maintenance, although the ECHO trial had acalabrutinib until progression, discussing amongst our group, we tend to favor a more of a time-limited treatment duration, seeing that a time-limited treatment duration in the triangle study, extrapolating from that is also one that offers very good outcomes and allows us to not expose patients indefinitely and lead to the development of mutant clones that are resistant to BTKIs. And then if you have a young or a fit patient and its patient's otherwise considered standard risk, based on the ECOG data that I showed, acalabrutinib plus BR or a BR alternating with HiDAC would represent as good induction regimens. And transplant can be considered only if patients do not achieve CR with undetectable MRD 10 raised to the power 6 by clonoSEQ. And this would be followed by maintenance rituximab for 3 years. If you have a high-risk patient on the other side, induction regimen similar to standard risk or the triangle study itself would also represent a good treatment option here. And transplant, again, is a very limited role now in the current era based on all the data that we have discussed, and again, reserved only to a patient who is otherwise MRD positive. And then in a high-risk patient, a combined BTKI plus maintenance rituximab maintenance strategy would be preferred rather than single-agent rituximab maintenance. And then, as we just discussed, TP53 mutation testing can significantly impact your choice of treatments, so should be tested in all newly diagnosed patients, and regimens such as the bovin having significant activity in TP53 can be considered in that subset, or if your patient is not responding to a chemoimmunotherapy regimen and is TP53 positive, you can transition to this regimen. So this is a whirlwind of our management of mantle cell lymphoma, but one that is very exciting, and it is very gratifying to see so much changes happening in the management of mantle cell lymphoma. Now we will talk a bit about relapsed and refractory mantle cell lymphoma and see what are our advancements and where the field is heading in this space. So we have known for several years now that median PFS with chemoimmunotherapy declines significantly by 70% actually from first line to second line, and then by 86% by the time patients reach third line therapy. So these are humbling numbers and suggest and shows the importance of developing effective regimens in this space also. Ibrutinib was the first covalent BTK inhibitor that was approved in 2013 by the FDA and the European Union for relapsed refractory mantle cell. And in a recent publication of pooled analysis of 3 trials with 10-year follow-up, overall response rate of 66% and PFS and OS of 12.8 and 25 months were reported. But they also were able to show that superior outcomes were observed when ibrutinib was used at first relapse, recommending that earlier use of BTK inhibitors is advisable. But we also know that 1/3 of patients develop primary resistance to ibrutinib, and overall survival for these patients is extremely poor. The 481S BTK mutations, ones that are frequently encountered in CLL, are actually infrequent in mantle cell lymphoma, and mantle cell lines exhibit resistance to BTKI treatments through alternative pathways. Next generation BTK inhibitors, both acalabrutinib and zanubrutinib, are now approved. Median PFS is slightly better than ibrutinib, but still somewhat limited at 22 and 33 months, respectively. And then we do not have any direct comparison, and it's unlikely to be generated across these covalent BTK inhibitors. But toxicity profiles are more favorable for the second generation, and these are recommended to be considered over our earlier generation ibrutinib. So how do we improve on what we see in the second line with single agent BTK inhibitors? So here we enter the era of the combination studies in the relapse space. And here I'm showing a table of several studies that have been done where ibrutinib has been combined with other agents, including rituximab, ixazomib, lenalidomide, venetoclax, and the most notable being the last one, which because it is a phase 3 study, the Simpatico trial, where ibrutinib was combined with venetoclax and was compared with ibrutinib. And superior outcomes were observed with ibrutinib in combination with venetoclax in terms of both median PFS and response rates, as shown. So the combination strategies are, in summary, associated with improved outcomes compared to monotherapy, and should be the preferred strategy, especially in patients with TP53 mutations, given inferior outcomes with monotherapy BTKI inhibitors. So as you can see, that risk stratification, as we just discussed in frontline management, continues to be important as we move on to the relapse setting, and is one that should be carefully considered at each time point. And lastly, we're going to talk a little bit about immunotherapy in mantle cell lymphoma. So CAR T cell therapy, as we are all familiar, has significantly altered treatment landscapes, and mantle cell lymphoma is no different. So here I'm showing long-term follow-up from the ZUMA study, where brexucabtagene, which is a CD19-directed chimeric antigen receptor T cell therapy, and was approved for patients with relapsed refractory mantle cell lymphoma. At a median follow-up of 35.6, which is the most recent update, the overall response is of 91%, with a 68% CR was observed. A median duration of response and PFS overall survival extending over 2 months, again confirming the highly effective nature of this treatment, over 2 years, confirming the highly effective nature of this treatment were confirmed. But also not something to ignore is the side effects associated with CAR T cell therapy. And here you can see the grade 3 or higher CRS and neurological events were observed in 15% and 31%, specifically a very high rate of neurological toxicity we can see with brexucabtagene. In the initial publication of brexucabtagene that led to its approval, similar outcomes were observed across the high-risk and standard risk subset. But in the real world, this is data from a consortium study that was published. Patients who did have high-risk subsets, such as TP53, complex karyotype, and so forth, they were noted to have a shorter PFS compared to standard risk patients in the real-world setting. And recently, we have also have another CAR T cell approval for patients with mantle cell lymphoma with lysocabtagene maraleucel, liso-cel. In this study, median number of prior lines were 3, with a range of 1 to 11, and with 30% receiving over 5 lines of therapy. So you can see a very heavily pretreated patient population. But despite that, high response rates of 83% and 72% were observed. Median duration of response in PFS were 15 and 15.7, 15.3. And interestingly, especially when we contrast with Brexucel, a much favorable toxicity profile with grade 3 or higher CRS occurring in only 1%, and grade 3 neurological toxicity or higher occurring in 9% of patients. So this is suggesting that liso-cel has a favorable toxicity profile, and perhaps that is the way to go for patients who are otherwise somewhat unfit or have medical comorbidities. So that is with the CAR T cell therapy, but there is other exciting stuff that is also going on in regards to immunotherapy in mantle cell lymphoma, and enter bispecific antibodies. These have been approved for some of our other B-cell lymphoma histologies here in the US, DLBC and follicular lymphoma, namely. We're yet to see an approval for mantle cell lymphoma, but data is exciting, and I anticipate that in the near future we will have some of these options available too. They are over-the-shelf treatments, so do not require apheresis or the other logistics that we deal with CAR T cell therapy. Glofitamab specifically has a novel 2-to-1 configuration with bivalency for CD20 and monovalency for CD3. 65% of patients in the single-arm glofitamab study had prior BTKI, and 73% were refractory to prior lines. Despite that, at a median follow-up of 8 months, granted the follow-up is somewhat limited, the overall response rates in CR were high at 84% and 73%, and there was no high-grade neurotoxicity. Other studies that are currently ongoing is the comparative study of glofitamab versus our standard of care, BR, lenalidomide, or lenalidomide and rituximab. This is an ongoing study, and I'm showing only the study schema, but an exciting and potentially a practice-changing study once it gets reported. More coming on, more studies with exciting results in immunotherapy is this study where mosunetuzumab, another bispecific antibody, was combined with polatuzumab, which is an antibody drug conjugate targeting CD79. Here, too, patients were heavily pretreated with a median 3 lines of therapy, all exposed to prior BTKI, with 85% being refractory. A lot of patients having over 50% having high risk prognostic factors as shown. Despite that, high response rates observed at 75%, 70% respectively, with the median duration of CR not being evaluable. Again, showing that bispecific antibodies have a strong potential to take up space in the future management of relapsed refractory mantle cell lymphoma. And then lastly, non-immunotherapy-based treatment alternatives upon failure of covalent BTKI, as not every person is eligible to receive immunotherapy for several reasons. Here we have some data supporting that venetoclax alone or in combination can also be an effective treatment option, and response rates of 40%, but unfortunately the outcomes are not that much durable, with median PFS and overall survival of 3.7, 12.5 months. We've also recently had an approval of a non-covalent BTKI, pirtobrutinib, that inhibits wild type as well as the mutant BTK phenotypes. And most importantly, pirtobrutinib is able to overcome resistance to conventional or covalent BTK. Overall response rate in this heavily pretreated BTKI exposed treatment population was 49%, and among patients who did respond, median duration of response was 21.6 months, which is excellent in a very heavily pretreated and a resistant population. So based on this data, pirtobrutinib is now approved in the United States for patients with relapsed refractory mantle cell after at least 2 lines of systemic therapy, and one that includes covalent BTKI. So how do we approach relapsed refractory mantle cell lymphoma? Here too, it's a nuanced and a situation, and one where we again have to consider several factors, and risk stratification again being centrally important. So based on if you have patient that has high risk features, as we discussed, that monotherapy covalent BTKI may not be optimal, and a combination strategy is a preferred treatment approach if possible. Secondly, CAR T cell therapy. Brexucell approval is after failure of 1 line of treatment. So this can be something to be considered early for a very high-risk population patient, rather than reserving CAR T cell therapy for a much later line of therapy. In your high-risk population, let's say if they do fail these very highly effective treatment options, you still have some options with pirtobrutinib clinical trials. And lastly, allogeneic transplant, although its role is significantly reduced in the management of mantle cell lymphoma, it can still be considered in a very selected patient who's otherwise eligible and meets candidacy for transplant, and can be considered as a consolidated treatment option. And in your standard risk patient, a single agent monotherapy covalent BTKI represents a good option as in your first relapse. And then in a subsequent relapse, we have several options with pirtobrutinib, combining covalent BTKI with venetoclax alone, and CAR T cell therapy. And subsequent to that, depending upon prior exposure, you still have option of pirtobrutinib, CAR T cell therapy, clinical trials, and allogeneic transplant as discussed. And with that, I would like to thank you all, my audience, for listening, and I would be happy to take any questions.
Thank you very much, Dr. Iqbal, for really an amazing, it was a sort of a tour de force where you managed to cover everything from diagnosis to relapse. And we've seen actually in this disease, when I trained 30 years ago, that was a terribly deadly disease, you know. Mantle cell lymphoma was a sort of a death sentence. Now, I think we've seen some amazing advances. We have a lot of questions. And the first question is, And I think it makes sense that not all mantle cell lymphomas are equal, and this is a relatively heterogeneous group of disease. Would you have a more personalized approach in certain entities?
Yeah, for sure. No, that is very much true. So as we discussed again, kind of pivoting to whether your frontline management or versus relapse refractory, but again, very correct that your individual patient needs to be taken into account. So again, I would pivot to understanding first a patient's performance status and then their individual disease risk factors. So taking both into consideration, as we discussed earlier, if you have an elderly patient who's otherwise standard risk, even though we have the data from the ECHO trial supporting BTKI addition, I prefer to reserve that for a higher risk patient and then still until we see some more advancement happening, considering BR, versus if you have an even more frail patient, you can get away with, especially with now approval of BTKI in the front line, you can get the covalent BTK and combine it with rituximab being a very effective and a tolerable tolerable regimen for these patients. So this is definitely very exciting to be able to give these very effective and tolerable treatments to patients. And then a similar approach, performance status, disease risk factors, young patients. And again, we saw somewhat contrasting data from the Triangle and the ECOG study. So over here too, we are pivoting towards considering either BR plus acalabrutinib or BR and cytarabine without a BTKI in a standard risk young patient, and then considering consistently combining BTKI in only a high risk patient in both the induction and the maintenance strategies. And then a standard risk, we could, because we do not technically have a comparative study for in the maintenance setting, we don't know whether rituximab maintenance versus rituximab plus BTKI is essentially superior or not. So we don't have that study, and I would think that would be a study that will be designed in the future. And then, as we discussed, one of the central takeaway point is that the role of transplant essentially eliminated to significantly reduced today based on some data from both the Triangle study as well as the ECOG study. So now in my management, we are routinely trying to incorporate MRD testing via clonoSEQ at end of induction. And if our patients are negative, which most of them will be, because we have very effective intense induction regimens now, then we will not be taking these patients to transplant.
Excellent, thank you. And I'll come back to the MRD because we have a few questions, but it's clearly well established now that BTK inhibitors are key drugs in this disease. And we know that there are different candidates, covalent, non-covalent. Is there a certain hierarchy for you among these BTK inhibitors? Irrespective of a label, I think from a scientific point of view. And then we have a question about the frequency of mutations with long-term ibrutinib maintenance.
No, definitely very important question. So ibrutinib, I think, is a very effective, and we have lots of data to support. But with the second generation, we do, even though there is no comparative study of ibrutinib versus, at least in the mantle cell lymphoma space, though there is some studies in the CLL space and other studies in other histologies. But looking at the cross comparison, the second generation BTK covalent BTKIs definitely have a more favorable toxicity profile. So in my practice, I do tend to prefer the use of acalabrutinib, in frontline as well as in a relapse setting if the patients are not, exposed to BTK inhibitors in the front line. And then obviously our non-covalent BTKI, as per the approval and the mechanism of action, is specifically, reserved for patients who have failed a covalent BTKI. So in that space, we currently just have pirtobrutinib, so that being our only option. But really the use of ibrutinib, and ibrutinib has been withdrawn also, as a side note, from the US market as of last year for further development in MCL space. So we are essentially, strictly limiting ourselves to the use of the next generation BTKIs.
Okay, thank you very much. We do have a question here about a few questions about MRD is when to perform MRD analysis, and is there a specific threshold you would look before using it to guide your treatment?
For sure, no, definitely. So, as per the ECOG, you are wanting to do your MRD analysis at end of your induction. So the clonoSEQ is the test that they used. So it's done by Adaptive Technologies here in the US, and it's the one that is validated. So until we see more data regarding from other tests and other platforms, we're trying to be purist and sticking with that test as that was the one that was validated, and it was to the 10 raised to power minus 6. So almost you can get results for MRD testing for all of your patients, provided that they had a good tissue specimen at the time of initial diagnosis, because that's what they will need, to identify a baseline clonal sequence and then to identify the end of induction. So to make your decision really, pretty much 2 to 3 weeks after your last cycle of induction, you can have the patient at the time of your end of treatment PET, because remember, it is a composite endpoint. You want to see a complete metabolic response, because if you don't have your complete metabolic response PET, then that's obviously is essentially a patient that you can consider for transplant based on the data that we have currently. So really, at your end of treatment PET scan, you can get MRD analysis drawn at that time.
Superb, thank you. One question from Dr. Kapik asking about the role of autotransplant in CR2 and beyond.
Yeah, interesting question. But really, I think it's really limited now, and probably one that is very limited data to support, sort of. I mean, you would think that perhaps there is still some efficacy, but I'm personally not familiar of how autotransplant would play off once you are refractory to your covalent BTKIs, So I guess that is the question, whether, autotransplant would have some efficacy, a chemotherapy-based regimen, once you're already refractory to novel BTKIs. So in the era of CAR T cell therapy, personally, in my practice, we have not been offering, and we haven't been doing autotransplant in that space.
Thank you. We'll take another two questions, I think, because we have a lot of questions. In those high-risk patients who are actually primary refractory at time of induction, what would be your salvage option?
Yeah, very good question. So obviously it will depend on what you use as your induction regimen. But thinking that, more kind of standard of care, if you based on a chemoimmunotherapy based regimen, I would try to go with a more of a novel treatment approach. Would try to get like if they did not receive a covalent BTKI in the frontline setting, so let's say a standard BR or like a BR alternating with high dose cytotherapy, then I would try to combine covalent BTK and venetoclax. So essentially, I would try not to use a single agent, novel agent, knowing that this patient has already declared that I have a more aggressive disease. And then we've seen that the data from covalent BTKI, they're not very durable, especially as a single agent. So I think a combination novel strategy or a clinical trial that offers something similar, as we saw in combination with the obinutuzumab and so forth, would be my preferred approach to take.
Excellent. One last question from Dr. Halder about the indication for allotransplant these days in a young fit patient who has a suitable donor.
I know that's a great question. So I think there is still some role for allogeneic transplant. I think some of the areas where you could potentially consider that are patients who are failing CAR T cell therapy, because we know that CAR T cell therapy has great response, but it's not something that works for everybody by any means. So I think patients who are failing post CAR T cell therapy are definitely candidates that you can consider for allotransplant after obviously they achieve response. Other areas where I think that can be considered is if, they develop, therapy-related neoplasms and those kinds of things like bone marrow failure syndromes, after exposure to, because often your allogeneic transplant patients are ones that have been exposed to several treatments and are at risk to develop, bone marrow failure syndromes or therapy-related myeloid neoplasms and so forth. So I think those are the situations. So post CAR T cell therapy, I think, is an area. Once you have a patient, although as I discussed, there are some of the options that you still have, but I think if you have a young and a fit patient who has failed CAR T cell therapy and you're seeing them today, definitely HLA typing is something to consider and start a donor search.
Wonderful. Thank you so much. So we have to conclude this insightful ICH webinar on the management of mantle cell lymphoma. I'd like, on behalf of the ICH community, to extend our gratitude to our expert, Dr. Iqbal, for sharing her knowledge and perspectives. I believe today's discussion has highlighted the evolving treatment landscape, the importance of personalized approaches, and the latest advancement that continue to shape patient outcomes. We do have a lot of challenges, but I think ongoing research and innovation will continue to offer promising avenues for improving care. As always, we do encourage collaboration and dialogue to refine these treatment strategies and optimize patient outcome. Wherever you are, thank you for your participation. Thank you for being loyal to the ICH, and we look forward to future discussions and to seeing you at other ICH activities. Take care, and thank you very much.